Okay, let's unpack this. Imagine an invisible world, one where tiny organisms, some no bigger than a speck of dust, others reaching the length of a small snake, live silently inside over 1 billion people worldwide.
1 billion? It's almost hard to grasp.
Exactly. These aren't just minor inconveniences. They're hidden guests that profoundly affect health, growth, and even the capacity to work. Today, we're embarking on a deep dive into something incredibly prevalent yet often overlooked: intestinal nematode infections.
Right.
We've compiled a stack of fascinating insights from Chapter 232, and our mission is to cut through the complexity, giving you the kind of understanding that feels like you're truly mastering the subject, the kind of nuanced knowledge held by elite professionals in this field.
Indeed. We're going to explore these parasites, unraveling their intricate life cycles, understanding precisely how they impact human health across the globe, and what makes them such a persistent, challenging presence in global public health.
Yeah, what makes them stick around so effectively?
Well, that's part of it. Our goal is to connect the dots, offering you not just the factual data points, but the why these infections are so critical and what it means for communities and individuals, allowing you to appreciate the full scope of these widespread conditions.
1 billion people.
Yeah.
That number is simply staggering and, frankly, a bit unsettling. It's almost incomprehensible to think that such a massive portion of humanity is living with these hidden guests.
It really is.
But beyond the sheer numbers, what's the real tangible impact on someone's life or on entire societies? Are we talking about just a mild upset stomach or something far more profound for global communities and individual human potential?
That's an excellent question, and it cuts right to the core of why these infections are a truly significant and often underestimated public health issue. What's fascinating here, and indeed quite tragic, is that while intestinal nematode infections are generally not fatal on their own meaning, they typically don't directly kill people.
Okay, that's important.
Right. But their chronic, insidious contribution to malnutrition and a significantly diminished capacity for work is immense. This isn't just about discomfort, it's about a profound, sustained drain on human potential, stifling individual development and, by extension, hindering economic progress in the regions most affected.
So it's a drag on everything.
Pretty much.
Yeah.
Think about the cumulative impact on a child's ability to learn, an adult's productivity in agriculture, or the overall health and resilience of entire populations. It's a silent, persistent burden that undermines progress and perpetuates cycles of poverty.
And where do we see them most?
Well, we see these infections overwhelmingly common in areas where basic infrastructure for fecal sanitation is poor, particularly in resource-poor countries situated in the tropics and subtropics.
Makes sense.
However, a crucial point often missed is their increasing frequency among immigrants and refugees who relocate to resource-rich countries.
So they travel with people.
Exactly. This highlights that the problem isn't confined to its originating regions, but travels with human populations, making it a truly widespread and interconnected global challenge.
So at their core, these are roundworms, essentially. And the sources mention they range dramatically in size, from just 1 millimeter, barely visible, to many centimeters when mature, up to 40 centimeters for some. That's a huge variation.
It really is. Quite a range.
And you mentioned their life cycles are complex and highly varied. Could you elaborate a bit on that? I noticed some can be transmitted directly person to person, while others require a specific environmental phase, like soil.
Precisely. You've hit upon a critical distinction that really defines these parasites. Intestinal nematodes are, at their core, a diverse group of roundworms. Their size indeed varies greatly, from minute organisms to surprisingly large ones, and the significant range often correlates with how they manifest clinically and the sheer impact they can have. Now, regarding their life cycles, it's a masterclass in parasitic ingenuity and adaptation. For certain species, like strongyloidiasis and enterobiasis vermicularis, commonly known as the pinworm, transmission is remarkably direct, often person to person, like hand to mouth or through close contact within a household.
Right, pinworms famous for spreading in families.
Exactly. That direct route explains why they can be so persistent and widespread, especially in settings like families, schools, or crowded communities.
But others need the environment.
Yes. Many of the other major players, including Ascaris lumbricoides, the giant roundworm, and the various hookworm species, require an essential environmental step. Specifically, their eggs or larvae must undergo a developmental phase in soil before they become infective to humans.
So soil contamination is the key link there.
Absolutely. It creates a strong, undeniable link between these infections and inadequate sanitation infrastructure. When human feces containing the parasite eggs are deposited in the soil, the eggs mature there. Once mature, people can become infected either by inadvertently ingesting these developed eggs from contaminated food, water, or hands, or,
Ascariasis.
yes, or in the case of hookworms, by larvae actively penetrating their skin from the contaminated soil, often when walking barefoot.
Ah, okay, so different entry points.
Right. And this brings us to a fundamental concept for understanding helminth infections. Most of these helminth parasites do not self-replicate within the human host.
Nemo.
Meaning, if you ingest just a few eggs or larvae, you'll develop a low burden of adult worms, which might be asymptomatic, you might not even notice.
Okay.
To develop a heavy burden of adult worms, which is typically what triggers noticeable clinical disease and more severe symptoms, you need repeated exposure to the infective stage, whether it's the egg or the larva.
So it's not just a one and done thing. You need repeated exposure to get really sick.
Precisely. Therefore, an individual living in an endemic area with poor sanitation is, unfortunately, often subjected to constant, repeated exposure over time. This continuous exposure leads to an accumulation of worms, eventually tipping the balance towards overt symptoms.
I see. So clinical disease, as opposed to a mild, often asymptomatic infection, generally develops only with prolonged exposure in an endemic area, and its severity is directly related to the intensity of that infection or the total worm burden.
You got it. This unique characteristic is crucial because it profoundly shapes how clinical disease manifests, helps us understand why certain populations are far more vulnerable, and it underpins the absolute necessity of sustained, community-wide public health interventions rather than just isolated one-off treatments.
That truly makes perfect sense. So it's a cumulative effect, which really underscores why these are chronic public health issues rather than acute passing illnesses. Beyond just the worm burden, what about the body's own natural response to these invaders?
The immune response. It's complex.
Our sources point out that in individuals with marginal nutrition, these intestinal helminth infections can significantly impair their growth and development.
Devastatingly so. When a child, for instance, has marginal nutrition, their body is already struggling. Layering helminths onto that means these parasites are actively competing for vital nutrients, leading to impaired absorption, sometimes chronic blood loss.
Which just makes the malnutrition worse.
Exactly. It compounds existing nutritional deficiencies, exacerbating conditions like anemia and stunting, effectively trapping individuals in a vicious cycle of poor health, reduced cognitive function, diminished educational attainment. It can have lifelong intergenerational consequences. It's a fundamental barrier to human flourishing.
And then there are specific immune markers, eosinophilia and elevated serum IgE levels. What do those tell us, and why are they important clues?
Right. Eosinophilia, an elevated count of eosinophils, a specific type of white blood cell, and elevated serum IgE levels are indeed common and highly characteristic features of many helminth infections.
So, like the alarm bells.
Pretty much. When a clinician encounters unexplained eosinophilia or unusually high IgE levels in a patient, especially one with a history of travel or residence in endemic areas, it should always prompt a thorough search for intestinal helminths. They signal a type 2 immune response, often associated with fighting multicellular parasites. They don't pinpoint a specific parasite, but they are a powerful red flag.
Okay, and perhaps the most intriguing part. The sources highlight the perplexing fact that significant protective immunity doesn't appear to develop in humans, even after repeated exposure. That's a real puzzle.
It is an absolutely fascinating puzzle and a key area of ongoing research. Despite the body mounting a clear immune response evidenced by the eosinophilia and IgE, it appears that humans generally do not develop significant, lasting protective immunity to intestinal nematodes.
We just keep getting infected.
Essentially, yes. It means we don't build up a durable defense that effectively prevents reinfection, which is precisely why individuals in endemic areas can be repeatedly infected over their lifetimes and accumulate heavy worm burdens. The exact molecular and cellular details of why the immune response fails to confer strong, lasting protection, well, that hasn't been fully elucidated. It's a complex frontier.
Especially when you also mention that these infections might actually protect some individuals from allergic disease. That seems almost contradictory, a surprising silver lining.
It is remarkable, almost counterintuitive. This concept is central to the hygiene hypothesis, or maybe more accurately, the old friends hypothesis.
Right, I've heard of that.
The theory proposes that early and sustained exposure to diverse microorganisms and parasites, our evolutionary old friends, helps train and regulate the developing immune system. Without such exposures, particularly in sanitized modern environments, the immune system might become dysregulated, leading to more allergies, asthma, eczema, even autoimmune diseases.
So the parasites might be calming the immune system down in some ways.
That's the idea some researchers are exploring. Could specific components of helminths offer immune modulation that might be therapeutically beneficial for modern inflammatory conditions? It challenges our traditional view of parasites entirely.
A potential upside to these ancient companions. Wow.
It's a surprising twist. And lastly, it's vital to briefly touch upon the very real concern of zoonotic connections. Humans can also be infected with nematode parasites that ordinarily infect animals.
Right, jumping from animals to us.
Exactly, leading to conditions like trichuriasis, anisakiasis, capillariasis, and abdominal angiostrongyliasis. This sets the stage for our later discussions, emphasizing how interconnected our health is with animals and the environment.
Okay, wow, that's a lot to consider. Complex interactions indeed. So let's now dive into the major players, the most common intestinal nematodes. We'll start with what sounds like the veritable king of them all, ascariasis, caused by Ascaris lumbricoides, the giant roundworm. I mean, 40 centimeters long, that's almost half a meter. To imagine that inside someone, it's genuinely shocking.
Indeed, Ascaris lumbricoides truly earns its title. It is the largest intestinal nematode parasite known to infect humans, capable of reaching that impressive length, roughly an adult's forearm.
Incredible.
But despite their size, the key insight here is that most infected individuals actually harbor relatively low worm burdens and are therefore completely asymptomatic. They might not even know they're infected.
So the big worms don't always mean big problems.
Not necessarily. Clinical disease, the kind that causes noticeable symptoms or severe complications, typically arises from one of two main scenarios, either from the migratory journey of the larval stage through the lungs,
Which causes its own issues.
right, or from the sheer bulk effects or aberrant migration of the adult worms once they are established in the intestines, especially if the worm burden is heavy or if worms wander into unusual, dangerous sites.
So let's really unpack its life cycle then, because understanding that is key. How does something that big actually get inside us, and what's its astonishing journey through the human body?
Okay, let's trace the remarkable journey of Ascaris. The adult worms live freely within the lumen, the open space of the small intestine. These mature female Ascaris worms are extraordinarily fecund, basically, incredibly prolific egg producers.
How prolific?
Each mature female can produce up to an astonishing 240,000 eggs daily. These eggs are then passed out with the feces into the environment. This high output is a primary factor in their persistence.
240,000 eggs a day. No wonder it's so widespread.
Exactly. And once in the environment, Ascaris eggs possess remarkable resilience. They're resistant to environmental stresses, but they need several weeks in warm, moist soil to mature and become infective.
And they last a long time.
They can remain infective for years in the soil under favorable conditions. This environmental hardiness makes eradication a formidable challenge.
Years. Okay, so how do we get infected?
Human infection begins when these infective embryonated eggs are swallowed, most commonly through contaminated food or water or direct hand-to-mouth transfer from contaminated soil.
Okay, then what happens?
Once ingested, the larvae hatch in the small intestine. These microscopic larvae don't stay put. They invade the intestinal mucosa, enter the circulation, and travel via the bloodstream to the lungs.
They go to the lung.
Yes. In the lungs, they break out into the alveolar spaces, the air sacs. From there, they ascend the bronchial tree, move up the airways, often causing irritation and that classic Ascaris cough.
Wow.
Once they reach the pharynx, the back of the throat, they are swallowed again, returning to the small intestine. It's there they finally develop into mature adult worms.
That's an incredible internal circuit.
It really is. The time from initial infection to egg production is typically 2-3 months. Adult worms live for 1 to 2 years inside the host.
That's a true biological odyssey for a tiny larva. And knowing that intricate life cycle, the epidemiology really starts to make sense. Widely distributed in tropical and subtropical regions, humid areas, transmission through fecally contaminated soil. So it's fundamentally a problem of sanitation and hygiene.
Absolutely. You've distilled the core problem perfectly. Its distribution is a direct reflection of its life cycle and the environmental conditions it thrives in: lack of proper sanitary facilities, open defecation, use of untreated human feces as fertilizer. Where these practices meet warm, moist climates, the soil becomes a vast, persistent reservoir for those incredibly resilient Ascaris eggs.
And younger children are most affected.
Yes, largely due to their natural behavior playing in soil, hand-to-mouth transfer. While most infections are in endemic areas, it's worth noting uncommon transmission can occur elsewhere, like through transported unwashed vegetables. Highlights the globalized food chain.
Given that dramatic migratory life cycle, what kind of clinical features do we typically see? Larvae migrating through the lungs must be noticeable.
Indeed, the clinical features present in distinct phases. During the initial lung phase, as larvae migrate, individuals may experience respiratory symptoms. Most common are a non-productive cough and a burning substernal discomfort, often worse with coughing or deep breaths.
Sounds unpleasant.
It can be. Less commonly, you might see dyspnea, difficulty breathing, and occasionally blood-tinged sputum. Fever can occur. And crucially, a hallmark is eosinophilia, elevated eosinophils in the blood, which develops during this phase and slowly subsides.
And I've heard the term Loeffler syndrome in relation to parasitic lung infections. Is that what you're describing?
Precisely. Chest imaging during this lung phase may show eosinophilic pneumonitis, often called Loeffler syndrome, typically transient, rounded infiltrates in the lungs, coming and going over weeks. In sensitized individuals in areas with seasonal transmission, you might see recurrent seasonal pneumonitis.
Okay, so that's the lung phase. What about when the adults are in the intestine?
Once the adults are established, the situation changes. Surprisingly, most established infections are clinically asymptomatic, especially with low worm burdens.
Really? Even with those big worms?
Yes, but the real potential for trouble begins with heavy infections, especially in children. A large bolus of entangled worms can cause severe pain and small bowel obstruction.
A physical blockage.
Exactly. And that can be complicated by serious life-threatening conditions like perforation, intussusception where the bowel telescopes, or volvulus, a twisting of the intestine. These are surgical emergencies.
Wow.
Beyond mass effects, single adult worms can cause dramatic disease by migrating into aberrant sites. A worm can enter and block the biliary tree, causing biliary colic, cholecystitis, cholangitis, pancreatitis, or rarely liver abscesses, mimicking gallbladder disease.
A worm in the bile duct.
Yikes. And migration up the esophagus can provoke violent coughing and even oral expulsion of the worm, a truly distressing event. In highly endemic areas, intestinal and biliary ascariasis can rival appendicitis and gallstones as causes of surgical acute abdomen. It's a significant burden.
That's quite a vivid and concerning picture. So how do clinicians definitively diagnose this, given the varied presentations, and what's the treatment?
The primary method is microscopic detection of the characteristic ascaris eggs in fecal samples. They're quite distinctive. Increasingly, PCR for ascaris DNA from stool is used, offering higher sensitivity, especially for light infections.
And sometimes people just pass a worm.
Sometimes, yes. The diagnosis is made quite dramatically when a patient passes an adult worm in stool, or, less commonly, coughs one up. They're easily identifiable by their large size and smooth, cream-colored surface.
What about during the lung phase?
During eosinophilic pneumonitis, larvae might be found in sputum or gastric aspirates before eggs appear in stool. Eosinophilia is prominent early, then minimal later. Imaging like contrast studies or plain X-rays might show worms or obstruction. Ultrasound and ERCP are key for pancreaticobiliary worms, and ERCP can sometimes extract them too.
And treatment?
Ascariasis should always be treated once diagnosed, even if asymptomatic, due to the risk of complications. Thankfully, several safe and effective drugs are available. Albendazole as a single dose, or mebendazole given over a few days or as a single dose. Ivermectin is also effective.
Any issues with these drugs?
They're generally contraindicated in pregnancy. Side effects are uncommon, usually mild diarrhea or abdominal pain. For partial obstruction, conservative management like NG suction and IV fluids might work, sometimes with piperazine via NG tube to paralyze worms. But complete obstruction or severe complications need immediate surgery.
Okay, that covers ascaris in incredible detail. Let's move to hookworm, which sounds like a bit of a biological vampire.
The bloodsuckers. Necator americanus, Ancylostoma duodenale, and Ancylostoma solanicum. Major consequence. Iron deficiency anemia. So they really are bloodsuckers.
They absolutely are, and that vampire analogy is quite apt. The hookworms are notorious for their blood-feeding habits. That's precisely why the major, most debilitating consequence of chronic, heavy infection is iron deficiency anemia, often accompanied by hypoproteinemia, low blood protein.
How do they do it?
These adult worms, about 1 centimeter long, attach tenaciously to the small bowel mucosa. Ancylostoma use buccal teeth. Nicators use sharp cutting plates to bite in. Then they actively suck blood and interstitial fluid.
How much blood? A single adult ancylostoma can consume about 0.2 milliliters per day. Multiply that by hundreds or thousands in a heavy infection, and you see how significant chronic blood loss, iron deficiency, and protein depletion can develop, especially in those with marginal nutrition. It's a silent, relentless drain.
That's a lot for such small creatures. How do they get into the body, not ingested like ascaris?
Correct. Their life cycle differs significantly in entry. Like ascaris, adults produce thousands of eggs daily, deposited with feces and soil. Under favorable conditions, warm, moist, shady soil rhabditiform larvae hatch. Over about a week, they develop into infectious filariform larvae.
And these are what infect us.
Yes. Hookworm filariform larvae actively penetrate intact human skin, usually when people walk barefoot on contaminated soil.
Through the skin. Okay. Then what?
Once they penetrate skin, they enter the bloodstream, migrate to the lungs, break into the alveoli, ascend the airways, are swallowed, and finally reach the small intestine.
Similar migration route to ascaris, but different entry.
Exactly. The journey from skin invasion to eggs in feces, the pre-patent period takes about 6 to 8 weeks, maybe longer for ancylostoma. Interestingly, ancylostoma larvae, if swallowed directly, can survive and develop in the intestinal mucosa, bypassing the lungs.
Shortcut.
Sort of. And adult hookworms can be remarkably long-lived, sometimes over a decade, though typically 6 to 8 years for A. duodenale and 2 to 5 years for N. americanus. This longevity contributes significantly to the chronic nature of the infection.
So penetrating skin from soil. Their prevalence must be tied to areas with limited footwear and sanitation. Where are they most common?
You're exactly right. Distribution is linked to suitable environment, warm, moist soil, and human behavior, especially walking barefoot where sanitation is poor. Ancylostoma duodenale is more common in southern Europe, North Africa, northern Asia. Nicator americanus predominates in the Western Hemisphere and equatorial Africa. Ancylostoma selanicum is most prevalent in Southeast Asia.
Can they overlap?
Yes, species overlap is common, especially in Southeast Asia, sometimes leading to co-infections. Age prevalence increases over time. Older children often have the greatest intensity. Also, older working adults in rural areas using human feces as fertilizer are often heavily infected due to prolonged contact with contaminated soil.
So what does a hookworm infection actually feel like? Obvious or insidious? What are the most debilitating aspects?
Often insidious, which is part of its danger. Most hookworm infections are clinically asymptomatic, especially with light burdens. People can be infected for long periods without knowing it.
But when symptoms do arise,
They can manifest at different stages. When larvae penetrate skin, they can cause ground itch, localized itchy maculopapular dermatitis, usually on the feet. In sensitized hosts, you might see serpiginous tracts of migration, like cutaneous larva migrants.
it's a creeping eruption.
Right. As larvae migrate through lungs, they occasionally cause mild transient pneumonitis, generally less frequent and severe than with ascariasis. In the early intestinal phase, symptoms might include epigastric pain, often warts after meals, inflammatory diarrhea, other abdominal discomfort, usually with eosinophilia.
But the main problem is the anemia.
Absolutely. The major consequence is chronic iron deficiency anemia. If iron intake is adequate, symptoms might be minimal. But in marginally nourished individuals common in endemic areas, the persistent blood loss leads to progressive iron deficiency anemia and hypoproteinemia. This manifests as debilitating weakness, shortness of breath, fatigue, impaired growth, and cognitive development. It's a fundamental drain on vitality.
Incredibly debilitating. So how do clinicians diagnose hookworm, especially when it can be asymptomatic? And what's the treatment? And are we seeing drug resistance?
Diagnosis is primarily by identifying the characteristic oval hookworm eggs in feces via microscopy. They're about 40 by 60 micrometers. For lighter infections, stool concentration procedures might be needed.
Do you tell the species apart by egg?
Not really under a standard light microscope. The eggs are virtually indistinguishable. PCR methods significantly improve species-specific diagnosis, important for epidemiology and tracking resistance. Also, if stool isn't fresh, eggs might hatch into rhabditiform larvae, which need careful differentiation from strongyloids larvae.
What are the clinical signs?
Clinically, hypochromic microcytic anemia pale, small red blood cells due to iron deficiency, sometimes with eosinophilia or hypoalbuminemia, is highly characteristic.
In treatment?
Several safe, effective drugs. Albendazole as a single dose, and mebendazole, also usually a single dose. For mild anemia, oral iron alone might suffice once worms are gone. Severe disease needs comprehensive nutritional support and robust oral iron replacement, along with deworming.
And resistance. You mentioned concerns.
Yes, there is significant and growing concern that benzimidazoles, mebendazole, and albendazole are becoming less effective against human hookworms. This is worrying as they're the cornerstone of mass drug administration. It limits options and highlights the challenge of parasite control.
A moving target.
Always. And briefly, zoonotic hookworms. Ancylostoma caninum, canine hookworm, can cause human eosinophilic enteritis, abdominal pain, intense local eosinophilia, treatable with mebendazole or endoscopic removal. Both A. caninum and A. brasiliensis cause cutaneous larva migrans, that creeping eruption.
Right. Okay, let's shift now to strongyloidiasis, the autoinfector. Unique among helminths for replicating within the host, persisting for decades. That sounds particularly serious, especially for immunocompromised people.
You're absolutely right. Strongyloidiasis is unique and insidious precisely because it can replicate within the human host, a feature shared only with Capillaria philippinensis. This allows ongoing cycles of autoinfection, internal production of infective larvae that re-enter the system, perpetuating the infection without further external exposure.
So it can just keep going indefinitely inside someone.
Potentially, yes. It means infection can persist for decades, even a lifetime, even after leaving an endemic area, a lifelong, often silent threat if not treated. The most concerning aspect is in immunocompromised hosts.
How so?
When host immunity is suppressed notably by glucocorticoid therapy, steroids, but also other immunosuppressants or conditions like HTLV-1 infection, the normal constraints on autoinfection are lifted. This can lead to hyperinfection, an overwhelming surge in larvae causing severe symptoms, or even disseminated strongyloidiasis.
Disseminated, meaning they spread everywhere.
Yes, massive numbers of invasive larvae spread widely throughout the body, CNS, liver, kidneys, heart. This is a medical emergency with high mortality.
So how does this autoinfection cycle actually work? A self-sustaining parasite. Truly terrifying.
It is one of nature's most sophisticated parasitic adaptations. The life cycle is complex. Besides the parasitic cycle in humans, it has a unique free-living cycle in soil, allowing it to survive and multiply without a host, contributing to its persistence.
Okay, how does the human cycle start?
Typically, infectious filariform larvae develop from larvae in feces, or after a free-living phase in soil, penetrate intact skin or mucous membranes, usually from contact with contaminated soil.
Similar entry to hookworm.
Yes. Once inside, they enter the bloodstream, migrate to the lungs, break into alveolar spaces, ascend the bronchial tree, are swallowed, and reach the small intestine. There they mature into adult worms, tiny 2-millimeter parasitic females. Crucially, they reproduce by parthenogenesis. No adult male is needed in the parasitic phase.
Wow.
Eggs hatch within the intestinal mucosa, releasing rhabdidiform larvae. These usually migrate to the lumen and pass with feces. However, and here's the autoinfection part, some rhabdidiform larvae, while still in the bowel, develop directly into infective filariform larvae.
Inside the gut.
Yes. These then penetrate the colonic wall or perianal skin, re-enter circulation, repeat the migration, lungs, throat, intestine, establishing ongoing internal reinfection. This continuous cycle is why it persists for decades without external exposure, a profound, chronic concern.
That is truly fascinating and terrifying. A parasite that keeps itself going inside you. Given this unique life cycle, where are strongyloids typically found? As widespread as ascariasis or hookworm?
Its distribution is spottier, more geographically delimited, but still a significant global issue. Common in tropical and hot, humid regions, Southeast Asia, Sub-Saharan Africa, Brazil, parts of Latin America. In the U.S., it's found in parts of the Southeast.
And in specific populations.
Critically, it's frequently encountered in immigrants, refugees, military personnel, or travelers from endemic areas. Clinicians in resource-rich countries must maintain high suspicion, even in non-endemic regions, due to its long persistence and risk of severe disease if immunity is compromised later.
What are the clinical features then? Beyond the severe risk for immunocompromised hosts, what about the common, uncomplicated infections persisting for decades?
In uncomplicated strongyloidiasis, it's varied. Many are asymptomatic or have only mild, subtle cutaneous or abdominal symptoms. Common cutaneous sign, recurrent urticaria, hives, often on buttocks and wrists. More distinct is larvicurans, running larva.
What's that?
A profoundly itchy, raised red lesion that visibly advances rapidly along larval migration, up to 10 centimeter hour. It's considered pathognomonic, almost always diagnostic of strongyloids.
Wow, you can see it moving.
Yes. Abdominally, adult parasites burrowing in the upper small intestine can cause epigastric pain, often resembling peptic ulcer but typically aggravated by food. Also, chronic nausea, intermittent diarrhea, GI bleeding, mild chronic colitis, weight loss, small bowel obstruction in early heavy infections. Pulmonary symptoms are rare. Eosinophilia is common, but levels fluctuate.
Okay, now the severe forms, hyperinfection and disseminated.
Right. Normally, immunity keeps autoinfection in check. If immunity is compromised, steroids, immunosuppressants, HTLV-1, this constraint is lifted, leading to hyperinfection, uncontrolled proliferation of falciform larvae, overwhelming worm burdens. This causes severe colitis, enteritis, or profound malabsorption.
And disseminated is even worse.
Yes, the most critical form. Larvae spread widely, CNS, peritoneum, liver, kidneys, heart. A major, often fatal complication is polymicrobial bacteremia. Larvae disrupt gut barriers, carrying enteric bacteria into the bloodstream. This causes severe gram-negative sepsis, pneumonia, or meningitis, often dominating the clinical course.
And you mentioned a paradox with eosinophilia.
Yes, perplexingly, in severe disseminated strongyloidiasis, eosinophilia, normally a strong hallmark, is often absent. This can mislead clinicians and delay diagnosis. Disseminated disease, especially with glucocorticoids, has very high mortality. It's a frequent complication of HTLV-1, but interestingly not common with HIV-1.
A truly detailed explanation of a deceptively subtle yet dangerous parasite. So how is strongyloids definitively diagnosed, especially when it's elusive, and what's the most effective treatment?
Diagnosing uncomplicated cases can be tricky. Definitive diagnosis relies on finding rhabditiform larvae in feces. They're small, 250 bem with a short buccal cavity, distinguishing them from hookworm larvae. But larvae are often passed in small, inconsistent numbers. Single stool exams might detect only 13 of cases.
So easily missed.
Very easily. Serial exams are strongly recommended, along with specific techniques like the agar plate method. PCR is also increasingly used for higher sensitivity specificity. Crucially, microscopy can be repeatedly negative even with persistent infection. Larvae might also be found in duodenal aspirate or biopsy.
What about blood tests?
Perhaps the most sensitive method for uncomplicated infections, especially for screening, is an ELISA for serum antibodies to strongyloids. Highly sensitive and recommended for anyone with geographic exposure history, unexplained eosinophilia, or, critically, candidates for glucocorticoid treatment due to the high risk of hyperinfection.
And for disseminated cases?
Falciform larvae should be sought actively not just in stool, but sputum, bronchoalveolar lavage fluid, surgical drainage fluid.
Treatment. It must always be treated.
Always, even if asymptomatic, due to the lifelong risk of hyperinfection dissemination if immunity drops later. Ivermectin is consistently more effective than albendazole. Standard for uncomplicated is ivermectin 200 bigram daily for 2 days. Albendazole is less effective.
And for severe cases?
For disseminated disease, ivermectin treatment needs extension, at least 14 days or 1 week after parasite eradication. For immunocompromised hosts, repeating the ivermectin course 2 weeks later is often recommended. If oral intake isn't possible, parenteral ivermectin, subcutaneous or intramuscular, can be used. Effective treatment is critical.
A comprehensive understanding of strongyloids. Okay, next up, trichuriasis, or whipworm, Trichurias trichiura. Similar to ascaris, most infections are asymptomatic, but heavy ones cause significant GI issues, especially in vulnerable populations.
That's right. Trichurias trichiura, the whipworm, named for its whip-like shape, is another significant soil-transmitted helminth. Globally distributed in tropics, subtropics, common among poor children where sanitation is inadequate. And yes, the vast majority of infections are asymptomatic, but severity relates directly to worm burden. Heavy infections can lead to significant GI symptoms.
How does whipworm get into the body and establish itself? Similar life cycle to ascaris.
It shares similarities in its reliance on soil for egg maturation. Adult trichuris worms reside primarily in the colon and cecum. Their long, thin anterior portions are threaded into the superficial mucosa, while the thicker posterior ends remain in the lumen.
Giving it that whip shape.
Exactly. Adult females lay thousands of eggs daily, passed with feces into soil. Maturation in soil is necessary for infectivity. Humans get infected by ingesting infective eggs from contaminated food, water, or hands. Eggs hatch in the duodenum, larvae mature, and migrate to the large bowel. Entire cycle takes 3 months. Adult worms can live several years, causing chronic infections.
And when symptoms do appear, particularly with heavy infections, what are they like? I've heard some severe ones, including a distressing complication in children.
In mild infections, tissue reactions are minimal. Most people have no symptoms, often no eosinophilia. But heavy infections can cause chronic anemia, less severe than hookworm, persistent abdominal pain, anorexia, and frequent, often bloody or mucoid diarrhea. This can strikingly resemble inflammatory bowel disease, posing a diagnostic challenge.
And the complication in children.
One of the most severe and visually distressing complications, particularly in children with massive trichuriasis infections, often compounded by malnutrition, is rectal prolapse. Intense irritation and inflammation, plus chronic straining, cause the rectum to protrude outwards, a very clear, painful sign of severe, long-standing infection.
Quite visceral indeed. How do we diagnose whipworm and what's the treatment?
Diagnosis is typically straightforward, primarily by identifying the characteristic barrel-shaped trichuriasis eggs in stool microscopy. They're distinct, with prominent polar plugs. Occasionally, adult worms, 3 to 5 centimeters, are seen on proctoscopy. PCR is increasingly used.
Treatment options?
Mebendazole as a single dose or albendazole daily for 3 doses are safe and effective options. However, cure rates can be modest, 30–90%, sometimes needing retreatment. Ivermectin is also safe, but generally not quite as efficacious as benzimidazole, specifically for trichuriasis. Highlights the challenge of complete eradication.
Now for something perhaps more familiar. Enterobiasis or pinworm. Anaerobius formicularis. More common in temperate countries, huge issue in places like the U.S., especially affecting children.
Absolutely correct. Anaerobius formicularis, the pinworm, is ubiquitous. Unique epidemiologically. More common in temperate developed countries than tropics. In the U.S., estimated 40 million infected, disproportionately children. Arguably the most common helminth infection in well-resourced nations. Highlights transmission dynamics less dependent on outdoor sanitation, more on direct person-to-person spread, and household hygiene.
So if it's not contaminated soil like ascariasis or hookworm, how does pinworm spread so easily, especially in families? A very different strategy.
Its life cycle explains its widespread, often household-bound presence. Adults, 1 centimeter long, dwell mainly in the cecum, key to transmission. Nocturnal migration of the gravid female worms. At night, females migrate out of the anus to the perianal region and release up to 2,000 immature yet rapidly infective eggs.
At night, around the anus.
Okay. These microscopic eggs become infective within hours, transmitted predominantly by direct hand-to-mouth passage. Children are efficient spreaders. From ingested eggs, larvae hatch in the small intestine, mature into adults in the large intestine. Life cycle 1 month, adults survive 2 months.
And self-infection is common.
Incredibly common. Scratching the itchy perianal region transfers eggs to hands, fingernails, then to the mouth. Easy person-to-person spread makes it common among family members, schools, daycares. Eggs are also light, can become airborne, settling on surfaces, clothing, bedding, aiding dissemination.
What are the clinical features? Just that infamous anal itching or more?
Yeah.
Eosinophilia common.
While most infections are asymptomatic, the cardinal symptom is perianal pruritus, intense anal itching, typically worse at night due to female worm migration. Persistent scratching, especially in kids, can lead to excoriation and secondary bacterial superinfection.
Any other symptoms?
Heavy infections are anecdotally linked to abdominal pain and weight loss, but much less common. Rarely, pinworms migrate aberrantly, invading the female genital tract, causing vulvovaginitis or pelvic peritoneal granulomas. Key diagnostic point. Eosinophilia is uncommon or absent, differentiating it from many other nematodes.
How is it diagnosed since eggs aren't typically in feces, and what's the treatment, especially to prevent family reinfection?
Critical distinction. Conventional fecal tests are largely unhelpful. Standard diagnosis is the cellulose acetate tape test or Scotch tape test. Apply clear tape to the perianal region first thing in the morning before bathing bowel movement. Transfer tape to a slide. Microscopic exam reveals characteristic oval eggs, 55 by 25 BIM, distinctively flattened on one side. Sometimes adult females, small white threads, are seen directly at night.
And treatment.
Mebendazole, single 100 milligram dose, or albendazole, single 400 milligram dose, are highly effective. Crucially, repeat treatment after 2 weeks to target newly hatched larvae. Also, treatment of all household members, even asymptomatic ones, is strongly advocated to eliminate reservoirs and minimize immediate reinfection, a classic household health issue.
That wraps up the major human-specific players. An extensive dive. Now, let's explore zoonotic connections when animal parasites jump to humans. First, trichuriasis, from herbivorous animals, often via contaminated vegetables.
That's right. Caused by Trichostrongyliasis species, normally parasites of herbivores like sheep, goats, cattle. occasionally infect humans, particularly in Asia and Africa where human-animal contact is close. Humans acquire it accidentally by ingesting larvae on contaminated leafy vegetables, often grown in pastures or fertilized with animal manure.
Do the larvae migrate in humans?
Generally not extensively. They mature directly into adult worms in the small bowel. They ingest far less blood than hookworms, so most infected persons are asymptomatic. Heavy infections might cause mild anemia and eosinophilia. Diagnosis is by finding eggs in stool. They resemble hookworm eggs but are larger, 85 by 115 bem. Treatment: mebendazole or albendazole.
And now, one relevant with global cuisine trends. Anisakiasis, from raw or undercooked saltwater fish. Anisakis simplex, Pseudoterranova decipiens, sounds painful, mimicking serious conditions.
Anisakiasis is indeed a gastrointestinal infection from ingesting nematode larvae Anisakidae family in uncooked saltwater fish and cephalopods. Incidence is rising globally, especially with popularity of raw fish dishes like sushi, sashimi, and ashiche. Historically common in Japan, Netherlands, Chile, a similar gastric syndrome can be caused by red larvae of eustrongyloid parasites from fish-eating birds.
What's their natural cycle?
Complex, involving marine food chains. Adults in marine mammals, eggs in seawater, larvae hatch ingested by crustaceans, then fish squid. Infectious third-stage larvae develop in fish musculature, accidentally ingested by humans.
So when someone gets anisakiasis, what are the clinical features? Immediate or delayed? How severe?
Can be quite acute and dramatic. Within 48 hours of eating infected fish, some might actually cough up live larvae. More commonly, live larvae try to penetrate the stomach mucosa. Within hours, this causes violent upper abdominal pain, nausea, vomiting, can closely mimic acute abdomen, appendicitis, perforated ulcer, leading to ER visits, even unnecessary surgery.
What if they pass the stomach?
Larvae may move to the small bowel, penetrate mucosa there. This provokes a vigorous eosinophilic granulomatous response. Symptoms might appear 1 to 2 weeks later. Intermittent abdominal pain, diarrhea, nausea, fever. This chronic presentation can resemble Crohn's disease. Also, increasingly relevant, ingestion of Anisakis proteins, even from dead larvae, can elicit severe allergic GI reactions, even anaphylaxis, in sensitized individuals.
How do you diagnose something mimicking other conditions, especially since eggs aren't found in stool? And treatment?
Critical challenge. Anisakid eggs are not found in stool as larvae don't mature in humans. Diagnosis most often via direct visualization during upper endoscopy. The burrowing larva can be seen, often extracted endoscopically, diagnostic and curative. Contrast X-rays might outline the worm or lesion. Histopathology of surgically extracted tissue is also diagnostic. Serologic tests exist but aren't widely available. Clinically suggested by imaging, confirmed by endoscopic surgical removal.
Prevention.
Straightforward. Adequate cooking, 60 degrees C, 140 degrees air, or freezing, negative 20 degrees C, 4 degrees F for 3 days, or commercial blast freezing. Importantly, larvae are not usually killed by salting, marinating, ceviche, or cold smoking. No effective medical treatment. Surgical or endoscopic removal is the only cure. Proper seafood prep is critical.
Powerful reminder. Next, capillariasis, the wasting disease, Capillaria philippinensis, insidious due to autoinfection.
Capillariasis from ingesting raw fish with Capillaria philippinensis is particularly devastating. Like strongyloids, it has autoinfection potential, leading to severe progressive wasting. Primarily found in Philippines, Thailand, occasionally elsewhere in Asia. Natural cycle involves fresh brackish water fish.
What happens in humans?
Ingested larvae mature into adults in the intestine. Adults produce invasive larvae within the gut. Continuous internal proliferation causes extensive intestinal inflammation, profound loss of villi, crucial for absorption. Clinical features start insidiously: nonspecific abdominal pain, watery diarrhea. Untreated, relentless autoinfection leads to severe protein-losing enteropathy, malabsorption. Can lead to death from cachexia, extreme wasting, cardiac failure, or superinfection.
Diagnosis and treatment.
Diagnosis by identifying characteristic peanut-shaped eggs, 20 by 40, a Menin stool. Severely ill patients need hospitalization, aggressive supportive therapy, nutrition, fluids, electrolytes, plus prolonged albendazole, 200 milligrams twice daily for 10 days, to eradicate infection and reverse malabsorption.
And then abdominal angiostrongyliasis. Sounds like a significant condition mimicking appendicitis.
Indeed. Caused by Angiostrongylis costaricensis, found in Latin America, parts of Africa, causes eosinophilic ileocolitis. Normally parasitizes rodents, with slug snails as intermediate hosts. Humans infected accidentally by ingesting infective larvae and mollusk slime on fruits, vegetables. Children at highest risk.
Where do the larvae go?
They penetrate the gut wall, migrate to the mesenteric artery supplying the intestines,
Mm.
develop into adults there. Eggs deposited in the gut wall provoke intense eosinophilic granulomatous reaction. Adult worms in arteries can cause mesenteric arteritis, inflammation, thrombosis, clots, or even bowel infarction, tissue death.
Symptoms.
Often mimic acute appendicitis, abdominal pain tenderness, often right lower quadrant, fever, vomiting, palpable mass. Lab tests show leukocytosis, high WBC, and significant eosinophilia. Diagnosis often challenging pre-op. CT scans show inflamed bowel obstruction. Definitive diagnosis usually surgical, often via partial bowel resection, identifying lesions, worm segs.
And finally, gnathostomiasis. Eosinophilic meningoencephalitis, brain infection, and migratory skin swellings. Sounds alarming and widespread in manifestations.
Gnathostomiasis from Gnathostoma spinogyrum larvae is serious with severe manifestations. Notorious for eosinophilic meningoencephalitis, brain membrane inflammation, migratory cutaneous swellings, or invasive masses in eye viscera. Found in many countries, endemic in Southeast Asia, parts of China, Japan.
What's its life cycle?
Mature adults in dog scouts' GI tract. Eggs and feces hatch in water, larvae ingested by cyclops, water fleas. Infected cyclops eaten by second intermediate hosts, fish, frogs, eels, snakes, chickens, ducks. Infective third-stage larvae develop in their flesh. Humans infected by eating raw undercooked fish poultry. Examples some pho, Thailand, sashimi, Japan. Some Thai cases from applying raw frog snake flesh as poultice. Skin injury.
So the varied severe symptoms are due to the larvae getting lost in humans, migrating aberrantly?
Precisely. Symptoms are entirely due to aberrant migration of a single larva. Humans are accidental hosts. Larva doesn't mature, just migrates, causing damage. Initial invasion, local inflammation, pain, cough, hematuria, fever, eosinophilia.
What are the specific symptoms?
Most characteristic. Painful, itchy, migratory cutaneous swellings, distal extremities, periorbital. Last 1 week, recur intermittently over years. Ocular invasion. Sight-threatening inflammation, most severe. CNS invasion, eosinophilic meningitis with myeloencephalitis.
How does CNS invasion present?
Agonizing radicular pain, paresthesias, and trunk lyme, rapidly followed by weakness, paraplegia. Cerebral involvement, hemorrhages, tissue destruction is often fatal. Extremely dangerous aberrant migration.
Devastating. How is it diagnosed given its chameleon presentation, and what's the treatment prevention?
Diagnosis often challenging, primarily clinical. Migratory swellings plus marked eosinophilia plus geographic dietary history. Crucially, ocular CNS involvement can occur without prior skin swellings. CNS cases show eosinophilic pleocytosis in CSF, often hemorrhagic xanthochromic, but worms almost never recovered from CSF. Surgical removal from skyni, if feasible, is diagnostic and therapeutic.
Treatment.
Albendazole or ivermectin may help. Efficacy unclear, especially for CNS. CNS involvement managed with intensive supportive care, high-dose glucocorticoids reduce inflammation, but prognosis often poor. Prevention is most effective. Adequately cooking fish poultry in endemic areas. Simple food safety averts catastrophic consequences.
Well, that was a truly comprehensive deep dive into the fascinating, often disturbing world of intestinal nematodes. It's abundantly clear these aren't just worms. They're a complex global public health challenge affecting potential and quality of life. The mastery we've gained feels substantial.
Absolutely. Connecting these threads, what stands out is the profound impact of basic sanitation, clean water, and safe food preparation on global health. Many are preventable, but require sustained infrastructural improvements, public health education, behavioral changes, not just periodic medication. Shows how deeply human health is intertwined with environment, socioeconomic factors, culture.
It really makes you think about simple things like food safety, travel, even in well-resourced countries. You assume you're safe, then hear about anisakiasis from sushi or persistent strongyloids from a trip decades ago. And the idea that these helminths might protect against allergies, that's where it gets really interesting. Like our bodies have ancient, unexpected relationships with them.
Indeed, it raises a provocative question. Could studying these ancient human-parasite relationships, how our immune systems co-evolved, lead to new insights for treating modern diseases like allergies or autoimmune conditions? It challenges our simple view of parasite as solely harmful, forces us to consider intricate biological balances. It's a cutting-edge frontier, harnessing lessons from our evolutionary past.
So what does this all mean for you, our listener, armed with this deeper understanding? Consider how interconnected public health, environment, food choices, our immune systems are in this complex dance. Does this deep dive change your perspective on global health initiatives, recognizing the silent burden beyond just fatality rates? or view the unseen world around and within us with new eyes, pondering the vast ecosystems shaping our health. It's a vast microbial world. We're just scratching the surface.
It's an invitation to reflect on the foundational role of basic services like sanitation, clean water, and public health education in preventing these widespread silent diseases. And perhaps, considering the unexpected evolutionary connections, wonder about other subtle ways our biology is shaped by the natural world, visible or not.